Unfortunately, this patient had about 2 years on the rucaparib therapy, but ultimately began having some increase in symptoms again. She had some abdominal bloating and fatigue. We were concerned, so we checked a CA-125. It was elevated up to 1,000. Subsequent imaging did prove that she had a recurrence of disease in her peritoneal cavity. Once you have a patient that has been on PARP inhibitor maintenance and has a recurrence, of course, you're going to look at the old standby platinum-free interval. This particular patient was off platinum for several years, and so retreatment with a platinum-based combination therapy makes a lot of sense. The options are the same as what we discussed before. You can combine carboplatin with a number of different chemotherapies: paclitaxel, pegylated liposomal doxorubicin, docetaxel, and gemcitabine. These things would again be discussed with the patient. You manage the toxicities, determine the logistics, and go forward with one of these platinum-based doublets. As far as if you can get that patient to another response, which a lot of these patients with germline BRCA mutations will have, their tumor will have another beautiful response to platinum-based therapy, then comes the question of what do you do? Can you reinstitute maintenance? This is a question we really don't have an answer to yet. Certainly it's tempting to retry a PARP inhibitor in a patient that has a target, but you gotta wonder, why did that tumor grow to begin with? And we do know that there is the development of resistance to PARP inhibitors. What we don't know is if a particular tumor develops resistance to one PARP inhibitor, is that resistance mechanism, can that be translated across all PARP inhibitors, or would a different PARP inhibitor perhaps work better? That question has not been answered yet, although there are studies that are either ongoing or in development that are hopefully going to tease that out. I think certainly PARP inhibitor alone may not be enough, and we have a number of different PARP inhibitor combinations that are in development with, across a number of different both targets such as anti-angiogenics or PI3 kinase pathway abnormalities, and then also combinations of PARP inhibitors with immune therapies, which are certainly very exciting. We don't know where they're going to fit, whether that be earlier on in the process or in a setting like this where you have progression on PARP inhibitor maintenance, but I think that we've got a lot of different opportunities that are in development. I think I've been doing this for a long time, and to have so many FDA-approved agents in the same setting now after having basically the desert before, where we had nothing to offer these patients except for chemotherapy, is really exciting. And I think now it's up to us to start teasing out who gets what when, and really kind of perfect our ability to use precision medicine in these patients.